Good morning, good afternoon, or good evening, everybody. It's a pleasure to see a whole lot of participants joining the October session of the 2021 ISPD Virtual Education Series. Thank you so much for joining us. I'm Tim van Miechem. I'm a maternal fetal medicine specialist at Mount Sinai Hospital in Toronto, Canada, and I'll be moderating today's webinar, which is focused on complex multiple pregnancies, including monochorionic twins and triplets pregnancies. So first we will hear from Dr. Liesbeth Lewi on monochorionic twins, and that will then be followed by a talk by Dr. Sabrina Craigo on triplet pregnancies. Now, before we get started, I have a few announcements to share. So first, if you need technical assistance and have problems hearing or seeing, please use the chat function for support, and we will try to help you as best as we can. Throughout the presentation, you can also submit questions for the presenters, now not through the chat function, but through the Q&A box. And we will address all these questions at the end of the session, and we'll hopefully have about 10 minutes to discuss both presentations. During the talks, you can also use the thumbs up button to vote up for questions. And so the ones with the most likes will come to the top of the list, and then we're more sure that those questions will be addressed. If we do have time for this, you may also choose to raise your hand to ask a question during the Q&A session, and I will then try to call on you to ask this question live. But we may sometimes be short on time and may not always have time for this. So if you do have burning questions, please put them in the Q&A box first. This event is also being recorded, and so if you don't want to be recorded personally, don't raise your hand, because if you come up during the question and answer for a live question, that will also be recorded. So that's it for practicalities. I'm now going to introduce our first speaker of the day, Dr. Lewi. So Liesbeth Lewi is a fetal medicine specialist and staff member at the Department of Obstetrics and Gynecology at the University Hospitals in Leuven in Belgium. And she's an associate professor at the Department of Development and Regeneration at the Faculty of Medicine at the University of Leuven in Belgium also, obviously. Her clinical work and research focus on complications in monochorionic twin pregnancies, and she's a world expert in this field, or maybe even the world expert in this field. She spent some time at the Harris Birthright Center in London with Professor Nicolaides in 2008-2009. She's completed a Global Clinical Scholars Research Fellowship at Harvard University in 2014-2015. And then last year, she spent 6 months working with us at the Ontario Fetal Center in Toronto. And we had the pleasure to share her knowledge or to profit from her knowledge for 6 months. She's published more than 170 peer-reviewed papers, many of which are in the field of monochorionic twins. And so she's the ideal presenter to give you an overview of how to look after monochorionic twins. Professor Lewi, please go ahead.
It's a little bit too much praise, but thank you for the kind invitation. And obviously, it's a pleasure to talk to you about what to look out for in monochorionic twin pregnancies. And I will also try to focus on what we tell our patients. So to start with what I'm going to talk about, the types of twins, the importance of getting the chorionicity correct in the first trimester. And then looking after monochorionic twins is basically looking for discordances, discordant anomalies, transfusion imbalances like twin-twin transfusion syndrome, twin anemia polycythemia sequence, differences in growth, and then the proposed follow-up scheme we have in monochorionic twin pregnancies. So the types of twins, and this is basic biology, so about 70% of twins are dizygotic, 30% are monozygotic, and obviously parents always want to know whether they're twins or di or monozygotic. But from an obstetric perspective, it's obviously more important to know how much placentas there are for each baby and how much amniotic sacs there are. Dizygotic twins, by definition, there's always a separate placenta for each baby. Whereas in monochorionic twins, we know that a minority of monozygotic twins are dichorionic, but the overall majority share a single placenta, and usually, fortunately, they still have separate amniotic sacs. So about 70% is monochorionic diamniotic, and then a very tiny minority, they also share the same amniotic bag. And these are the monoamniotic twins, which I will not address in this talk. Now, dichorionic twins, we know that this depends on genetic factors. They run into families, and also they are more common in African population than Asian population. The risk increases also when mom is older, and the overall contributor to dichorionic dizygotic twins is obviously assisted fertility treatment. Now, monozygotic twins, they are fairly constant around the world, and we don't know, this is actually a natural cloning process. We don't know why the one fertilized egg splits into two clones, and we see an overall incidence of about 1 in 250 pregnancies throughout the world. So every woman that gets pregnant has a chance of conceiving monozygotic twins in about 1 in 250 instances. Now here, it's important to mention that because in Belgium, we have a policy of single embryo transfer, so the fertility treatment is reimbursed, provided that preferentially only one embryo is put back. And we know that, that fertility, IVF, as well as ovulation induction, increases the rate of monozygotic twinning. Also, the reason why is not well understood. But importantly, we know that after a single embryo transfer, the chances of walking out with monozygotic twins is about 2%. So the incidence after IVF treatment is about 1 in 50. So 5 times higher than the natural incidence of 1 in 250. And I would like our fertility colleagues, I don't know if they are listening, but to warn patients that, of course, single embryo transfer is very important to reduce the rate of twinning, but still there is a 2% risk of monozygotic cleavage. Now, why is it important for the obstetrician and the fetal medicine specialist? Well, dichorionic twins have separate placentas, although at the time of birth, they're usually fused into one placental mass, but they have this thick chorionic layer, and so each baby has a separate circulation, and they're like a brother and a sister, or two brothers and two sisters who happen to be in the womb at the same time, but they're not connected to one another, and so their well-being is not interrelated, and also they cannot develop any transfusion imbalances. And so about 80% of all the twins are dichorionic, and about 20% of the twins we see are monochorionic. And the problem here is not so much that they share a single placenta, but certainly the fact that about 95% of these monochorionic twins have these vascular communications. And obviously, through these communications, about 15% develop some kind of transfusion imbalance. And also, obviously, because of the shared circulation, their well-being is interrelated. So if one baby dies, the other baby can die as well or sustain severe brain damage. And just to illustrate that the monochorionic twins are the ones that need special attention, is the fact that especially the risk of loss prior to viability is 4 times higher. They have twice the risk of perinatal death and very preterm birth. And also for their development, although in the overall majority, these twins are born healthily, and we know that their risk of some form of developmental delay is twice as high as in a dichorionic twin pair, and also their risk of cerebral palsy is 4 times higher. And the excess mortality and morbidity in monochorionic twins is related entirely to their shared circulation. And therefore, once more, to show that it's important that we identify these high-risk monochorionic twins in the first trimester by looking at what separates the babies. So in monochorionic twins, you only have 2 thin amniotic layers, so in the monochorionic diamniotic twins, whereas in dichorionic pairs, you have a thick chorionic layer, and then 2 separate amniotic layers on each side. And so the ideal time is in the first trimester, because after 14 weeks, then amnion and chorion fuse, and it's much more difficult to establish if same-sex twins are mono or dichorionic. Now, the complications then in monochorionic twin pregnancies, well, I also I look at the complications like Russian nesting dolls. So in the sense that different complications can go together, but there's always one complication that prevails because it determines the management. So what usually determines the management is whether both twins are healthy, look healthy on the ultrasound scan. So discordant anomaly it overrules at the diagnosis of twin-twin transfusion syndrome, because obviously the treatment, if you have a twin-twin transfusion syndrome, but for instance, anencephaly in one of the babies, then the management will be determined by the presence of an anencephalic baby, and parents will choose for selective reduction rather than laser treatment. And the other discordance is a discordance in hemoglobin levels between the twins, which we call TAPS. And we know that TTTS and TAPS can go together, but if they go together, the diagnosis of TTTS prevails, because obviously here we would certainly offer laser treatment as the first line treatment. And then finally, differences in size. So difference in size between the twins can occur together with transfusion imbalances, but we call it isolated discordant growth when there is no TTTS and when there is no differences in hemoglobin levels. And if none of these discordances are present, then we can call the pregnancy uncomplicated from a fetal perspective. And I'm going to discuss these complications briefly in this order. So discordant anomalies occurs in about 1 in 10 monochorionic diamniotic twin pairs. And obviously we know that monochorionic twins are more common to have structural anomalies as compared to dichorionic pairs or singletons. And you would think monochorionic twins, they are monozygotic as a rule. So if I have checked one baby on ultrasound scan, I can forget about the other one, because if one is normal, the other one must be normal as well. Now that's certainly not the case. And so in 80% of cases, only one baby is affected. And the reason why we see more anomalies in monochorionic twins is obviously because of the monozygotic cleavage, which can be teratogenic, and obviously complications of the shared circulation, like acardiac twinning or right heart dysfunction with functional pulmonary atresia, brain hemorrhages, limb amputations because of twin anemia polycythemia sequence or twin-twin transfusion syndrome. So monochorionic twin fetuses have twice the risk of structural anomalies as compared to singletons. So if you're scanning 10 monochorionic twin pairs, you should see one pair where one baby has an anomaly on average. And so they deserve detailed follow-up scans. Chromosomal abnormalities, on the other hand, are 3 times less common than in singletons, and we think that when you have a chromosomal anomaly, you're less likely to survive the monochorionic setting. So you have to be chromosomally healthy to survive the setting as a monochorionic twin pair. But obviously, since they're monozygotic, most of the time both are affected. But here, it's important to realize that it may be, even if they are monozygotic, that only one baby has the anomaly. And since they are monozygotic, you can also use the NIPT test to screen for chromosomal abnormalities, although it must be said that we have limited data, but from a theoretical perspective, the NIPT test should be as accurate as in singletons. Now, why can you have the situation which we call heterokaryotypic monochorionic twins, where one twin, for instance, has Down syndrome and the other one is normal, whereas it's a monozygotic twin? Well, we know that when we start as early embryos, that there are a lot of mistakes in the cell division. And for instance, we can start with trisomy 21 with Down syndrome. And then in the subsequent cell division, one group of cells may lose the extra chromosome 21 and end up with a normal karyotype, whereas the other cells continue to divide with the extra chromosome 21. And actually that may promote a twinning event, and the fact that there are two different cell groups. And so it's important to think about that, because if in the first trimester, and this has been described for all common aneuploidies, but also for the more subtle chromosomal rearrangements like deletions and duplications, the implications are that when you have discordancies on the first trimester scan, so one monochorionic twin with a thickened nuchal and one that looks completely normal, then we recommend to do a double amniocentesis at around 16 weeks rather than a chorionic villus sampling, because you can miss the fact that one baby has the aneuploidy by sampling the shared placenta. But if the result is abnormal of your CVS, you may miss the fact that actually one baby is completely normal. And so whenever you see discordances, your preferred test is to do a double amniocentesis just to pick up these heterokaryotypic monochorionic twins. How do we manage severe discordant anomalies in a monochorionic setting? So you cannot use intracardiac potassium like in a dichorionic twin, because obviously because of the shared circulation, it will embolize to the healthy baby. So we have more advanced techniques that are only performed after 16 weeks, either intrafetal coagulation or cord coagulation, to perform the selective reduction. And so when the anomalous twin has an anomaly that threatens the well-being of the healthy twin, like a trap sequence, or when there is coexisting TTTS, or when baby has lethal Turner syndrome or an Epstein's anomaly, then we would prefer to do an immediate reduction, which then can be performed from 16 weeks onwards, where you have an 80% survival of the healthy baby, but still a 20% risk of birth before 32 weeks. And in Europe, we have the permission to perform late reduction. And also in Canada, it's the case. So if there is a severe anomaly that does not threaten the well-being of the other baby, like hydrocephaly or spina bifida or severe Dandy Walker, then parents can opt for a late reduction in the viable period. And then obviously there cannot be any miscarriage anymore of the other fetus, but obviously we know that about 1 in 5 still delivers very preterm. You avoid the extreme preterm births, but still 20% will deliver soon after your late reduction. Obviously, when you expect an early neonatal demise, that's when parents can choose for comfort care after birth, and then you avoid all procedure-related losses and preterm births. Then twin-twin transfusion syndrome, it's the most important reason why we lose monochorionic twins or why they sustain long-term handicap. It's about 1 in 10 monochorionic diamniotic twins. And it's basically a severe difference in amniotic fluid volume. And we have strict criteria. So the donor baby, and don't get fooled about the cocoon sign, as sometimes we get referrals where it says the donor still has more than 2 centimeters deep pocket, but you can easily distinguish the fluid from the donor because it's more echogenic. And so the donor should have a deepest vertical pocket of less than 2 centimeters and usually has a small or empty bladder. Whereas in the recipient twin, we use a gestational age dependent criteria because the smaller the baby, the less it can be. And so the less large, the deepest vertical pocket. And usually this recipient baby has a distended bladder. And most of the TTTS cases actually in our series, 85% occurs prior to 26 weeks. And so if nothing is done, then usually this results in the loss of the entire pregnancy. And as I said, it's the most important complication in monochorionic twins. And that's also why it's recommended that all monochorionic twins have an ultrasound scan every 2 weeks, where we check for the bladder filling and whether we can see the intertwin membrane free floating between both babies. We also, obviously, otherwise it's not necessary to screen. We have a good treatment for it, which is fetoscopic laser coagulation of all the communicating vessels. So we coagulate all the vessels that connect the babies. And then at the end, we also draw a line from one edge to the placenta to the other edge of the placenta, connecting all the dots. And so we inject all our placentas, all our monochorionic twin placentas, and this is a placenta after laser treatment where you can nicely see the coagulation line. And so we tell our parents that the chance of taking home both babies is about 65%, of one baby surviving about 20%, and in 15%, unfortunately, there are no surviving infants, and that's mainly because of miscarriage or extreme preterm birth. On average, unfortunately, they deliver very preterm, and overall, there's also remains a significant risk of some form of impairment, and also about in 6% of surviving TTTS infants, there is cerebral palsy. So these children deserve follow-up in infancy to screen for any delay in their development. Another transfusion imbalance in monochorionic twins is twin anemia polycythemia sequence. So it's not so much a difference in amniotic fluid, it's a difference in hemoglobin levels between the twins, and it's caused by minuscule anastomosis. So the placentas are very different than from TTTS. If you inject the TAPS placentas, you think there are no connecting vessels, but when you look very, very carefully, you see tiny communications. And so TAPS is caused by a net chronic transfusion of red blood cells from one baby to the other. And spontaneous TAPS is also not so common as twin-twin transfusion syndrome. It occurs in about 1 in 20 previously uncomplicated monochorionic twins. And we can detect it prenatally by measuring the middle cerebral artery peak systolic velocities, where in the polycythemic twin you have decreased velocities, and in the anemic donor baby, you have increased velocities, but you can also go by the difference in middle cerebral artery peak systolic velocities between the twins. Now, besides measuring the middle cerebral artery peak systolic velocity, you can also suspect TAPS by looking at the placenta, because in TAPS you typically have a placental dichotomy where you have a thick and wide part of the anemic donor baby and a dark flat part of the polycythemic recipient. And also the livers look very different. In the polycythemic recipient, you have what we call the starry sky aspect. So a very dark liver with the bright venules very visible. So these are additional, these signs support your TAPS diagnosis additionally. And also, in contrast to twin-twin transfusion syndrome, TAPS is something that occurs in the viable period. So usually after 26 weeks, and it's probably an important cause of previously unexplained stillbirth in monochorionic twins. Now, the best management we don't know. So for early cases in the pre-viable period, we offer laser surgery like for TTTS. And as you can see, the vessels are minuscule and few. But that's obviously a causative treatment. When there's a severe anomaly in one of the twins, then you can offer a selective reduction. After viability, you can gain some maturity by giving intrauterine transfusion to the anemic donor baby. And also, if you have to give a lot of transfusions, then you can also give exchange transfusion to the recipient twin. Or if it's mild and very early or late in pregnancy, you can also be expectant and plan an elective preterm birth. Now, there's currently a randomized controlled trial, the TAPS trial, that examines whether fetoscopic laser surgery is superior to one of the 3 other managements. And then finally, a difference in size between the babies. That's quite common, and it's as common in monochorionic as in dichorionic twin pregnancies. And in clinical practice, it's useful in monochorionic twins to use the cutoff of more than 20% difference in estimated fetal weight. And so the larger minus the smaller divided by the estimated fetal weight of the larger baby. And it's always abnormal in monochorionic twins because they're monozygotic and they have the same genetic growth potential. And obviously here, the problem is if the smaller baby dies, the other one can sustain brain damage because of exsanguination across the anastomosis. And it's a diagnosis that's only made when there is no TTTS and when there is no TAPS. So that's isolated selective fetal growth restriction. And then the prognosis is largely determined by the umbilical artery Doppler pattern in the smaller baby. And type 1 are the ones where the Dopplers are normal in the smaller baby. And that's fortunately, the overall majority of selective fetal growth restriction, there is still normal Dopplers. And these type 1 cases actually do extremely well. And also their outcome is like for uncomplicated monochorionic twins, but we deliver them a little bit earlier, usually around 34, 35 weeks. The type 2 and the type 3 cases, at type 2 is when there's a continuous absent end-diastolic flow, and the type 3 cases are the ones that cause an important cause of fetal loss and also extreme preterm or very preterm births. Now, the type 2 cases, those with the continuous absent or reversed end-diastolic flow, where you have a uniform pattern of either absent or reversed flow. Here, the growth discordance is very pronounced between the babies, whereas if we inject these placentas, they are actually not so unequally divided. And usually the pathologist finds signs of maternal vascular malperfusion lesions like infarctions in the part of the smaller baby. And they have tiny anastomosis. So here, the growth-restricted monochorionic twin behaves like a singleton baby with growth restriction. And that's the advantage in the sense that you will see signs of progressive worsening of its condition with abnormal ductus venosus, oligohydramnios, that then predict imminent demise. So in type 2 cases, you can predict demise of the smaller baby, but the disadvantage is that they have the poorest outcome, only 60% survival. The type 3 cases are the ones where you have this typical variation in flow, where in one sweep it goes from normal to absent to reversed. Here, the growth discordance is less pronounced, so usually there are 20–25% difference, but the placenta is extremely unequally divided between the babies, and there are huge and a lot of anastomosis. And so if you were to perform laser surgery, obviously the smaller baby would have too little placenta to survive. And the intermittent pattern is caused by the presence of a large artery-to-artery anastomosis that you can pick up by pulse wave or color Doppler. And that's also the reason why you have to sample the cords in monochorionic twins with selective fetal growth restriction at the place of the cord insertion itself. And they have an intermediate prognosis, so 85% survival. But the problem here is that because of the large artery-to-artery anastomosis, there can be an unpredictable demise of the smaller twin. And then because of the extensive blood exchange, often also demise of the appropriately growing twin. And so the best management, well, most of the time we are expectant, even if there are abnormal Dopplers in the smaller baby. And we know that in type 2, there's the 60% survival, and most type 3 cases do quite well. Obviously, if there is a discordant anomaly, or in type 2, if you see signs of imminent demise of the smaller baby, or on parental request, a selective reduction can be performed. But obviously, the overall survival is only 40% because you lose a smaller baby, and there's only 80% survival for the larger twin. And then fetoscopic laser surgery can be done as for twin-twin transfusion syndrome, but the outcome here is certainly not as good as in twin-twin transfusion syndrome, although there is a large variation in the literature. But we don't tend to offer that because selective fetal growth restriction is not caused by the anastomosis. And if you want to protect a larger baby, we believe then that the selective reduction is the safer option, because you always have also a 20–30% risk of loss of the larger twin. So that's what I wanted to tell you. The follow-up screen for monochorionic twins is the chorionicity determination in the first trimester, and then a every 2 weeks scan where you look for discordances. And then importantly, by 36–37 weeks, we offer an elective birth. Because we know it's the best time to be born for monochorionic twins. So looking at monochorionic twins is looking for discordances. It's important, every twin should have the chorionicity determined in the first trimester, and the monochorionic twins should have an ultrasound scan every 2 weeks to pick up early these discordancies, especially twin-twin transfusion syndrome. Thank you very much for your attention.
Thank you very much, Dr. Lewi, for that very comprehensive presentation. Unfortunately, we needed to stick to 20 minutes, but I'm sure you have lots more to tell us, and we can certainly address that in the question and answer session that will be at the end of the second talk. I see that some people have already started putting some questions in the Q&A, so we will definitely address those at the very end. The second talk will be delivered by Dr. Craigo, and Dr. Sabrina Craigo is the professor and vice chair of obstetrics in the Department of Obstetrics and Gynecology at Tufts University School of Medicine and Tufts Medical Center. Dr. Craigo received her medical degree from West Virginia University School of Medicine and completed her residency in OB-GYN at Charleston's Area Medical Center. She moved to Boston to complete a maternal fetal medicine fellowship at Tufts, and she spent her career there to date. She's been the MFM division director and fellowship director for 20 years and has served on many national committees through ACOG, SMFM, and she's a board examiner for ABOG. Her clinical interests are broad and include prenatal diagnosis, clinical obstetrics, and medical problems in pregnancy. And of relevance to her talk today, she was the senior author on the recent publication in prenatal diagnosis on how to counsel the parents on triplet pregnancies. Dr. Craigo is a highly recognized teacher, and she's received numerous teaching awards from students, residents, and fellows. And so I'm looking forward very much to her presentation. Dr. Craigo, please go ahead.
Thank you. Just trying to get this. I can see. There. Thank you for that introduction. I'm going to start and talk about triplets, which is something near and dear to my heart. I have enjoyed caring for these patients and gone through trials and tribulations with them over many years. And this is just an outline. I won't read it out loud to you, but we're going to kind of just start and go over the incidents, but then go over the things we need to think about early in the pregnancy, and then how to manage these patients. And as the title of the recent article was, how do we talk to patients about this? I think that's a particularly challenging thing. If you can imagine trying to talk to your patients early on about all the things we just heard from Dr. Lewi about monochorionic twins, it's challenging, and it needs to be done in this very tight time frame. The incidence of triplets has changed dramatically over the years. Spontaneous triplets are about 1 in 8,000 pregnancies. Currently in the US, it's around 1 in 880. And the peak was around 1 in 500 in 1998 during those years of unfettered ART. And at that time, at our hospital, we were seeing, which is a referral center, we were seeing about 1 in 100 or 1 in 150 patients with triplets. So we had a lot of experience during those years. We're happy to know that the recent changes with ART and the single embryo transfer and all the things that have been put in place to try to reduce that have shown a difference. But as we just recently heard, even with the single embryo transfer, you can still get a multiple gestation. And this is particularly higher. There's a higher number in those who are having ovulation induction, which is sometimes unmonitored and a little unpredictable. We have a fair number of patients presenting with spontaneous triplets as well. The contributors include the ART, as I just talked about, and also increasing maternal age. And on the right, you'll see the CDC info on the later maternal age that's happening all around the world, but certainly in the United States. And we see that women who are in their mid to late 30s, as well as in their 40s, the rates continue to rise. That, of course, goes hand in hand with the ART, and we will go through that more. Early diagnosis is essential, and to allow for appropriate counseling. If someone finds out they have triplets at their second trimester anatomy scan, it's really many options are off the table at that time. So first trimester ultrasound establishes dating, and it's really important to look at chorionicity and amnionicity and to label from start to finish. So labeling the fetuses, A, B, and C, the placentas, and position in the uterus and the fetal sex early on, and documenting, because we're following these patients throughout their pregnancy, and you need to be able to compare growth and abnormalities with what you saw before with, know that you're comparing to the same fetus at each visit. Placentation, we just saw some nice images about this, but I'll just remind you of the T sign that was suggesting monochorionicity, where the membrane goes directly into the placenta, the lambda sign showing dichorionicity, and the these are switched, I think, and the epsilon sign is this Mercedes sign of the 3 trichorionic placentation. Nearly all obstetric complications are increased with multiple gestation, except for maybe postdates and macrosomia. There have been documented over the years increased risk of gestational diabetes, hypertensive disorders, antenatal bleeding, anemia, and preterm labor, as well as hyperemesis. The risk of antenatal admission approaches 100%, and only around 40% are for complications other than preterm labor. So preterm labor drives that, but they're often admissions for hypertension or these other complications. There is also an increased risk of cardiac disease and acute or chronic lung disease when compared to women who are just carrying twins, for example. I will say that some of this data is very limited because, as I mentioned, the peak of twinning of triplets were back in the late 90s, and at that time people had a lot of good experience. As the numbers have gone off, the interest in like publishing information in any one center has become less and less. So I'll note that when there is more data. Fetal risks include an increased risk of aneuploidy. This is just a numerical risk, like the idea of like rolling the dice more than once. So if you have a patient who's 35 years old and there's 3 trichorionic trizygotic embryos, then the risk is about 1 in 270 plus 1 in 270 plus 1 in 270. So around, around 3 in 270 or 1 in 90. So that's more like a 28-year-old. So they do have a slightly higher chance of aneuploidy, not from the multiple gestation itself, but just simply because there's 3 embryos. There's also an increased risk of anomaly. Again, this is numerical, not like with the monochorionic twins, but if there is a monodipe pair, then that certainly applies even in the triplet setting. There's an increased risk of miscarriage. Of those diagnosed at 5 to 6 weeks, and many of these are going through ART, about 50% have a spontaneous reduction of 1 or more by 12 weeks. The risk of loss before 24 weeks is at least 15 to 18%. I think that's important for patients to understand early on. There's also an increased risk of IUFD that is related somewhat to chorionicity, but even in trichorionic triplets, the rate is around 0.8 or near closing in on 1%. The increased risk of preterm delivery approaches 100%, and that's driven by preterm labor, but also indicated preterm delivery for maternal complications. The chance of delivery before 34 weeks is about 50%, and the ones we most worry about, of course, are those patients who deliver before 28 weeks or extreme prematurity, and that ranges from 8 to 17%. The risk doesn't stop there. There's actually a 3-fold risk in infant death of 1 or more babies, and one of the most important risk factors for this, of course, is the prematurity that is so common in this group. The vast majority of patients are delivered by cesarean delivery, most often due to malpresentation. And cesarean for triplets carries increased risk of postpartum hemorrhage, blood transfusion, and also cesarean hysterectomy, mainly due to the overdistension that we all see. Vaginal delivery can be considered if you have certain things in place in your particular center, including that the patient is well counseled, triplet A is vertex, the gestational age is over 32 weeks, the estimated fetal weight is over 1,500 grams, and there's no significant discordance. You have anesthesia present, and the delivering provider has skills in breech delivery. Having said that, we usually advise patients to have a cesarean delivery because of the potential complications. And it's hard to line this all up. In the data for the Consortium for Safe Surface Labor, there was a secondary analysis that looked at the patients who wanted to have a trial of labor, wanted to have a vaginal delivery with triplets, and even with things in place to allow that to happen, only 16% actually had a successful vaginal delivery. And attempted vaginal delivery was associated with a higher risk of maternal transfusion and more frequent need for mechanical ventilation of the neonate. There are some single center studies. There's one retrospective study that recently showed about a 57% successful vaginal delivery rate for those attempting trial of labor, but they were small numbers over 11 years. There was no increase in maternal or fetal morbidity, but of course it wasn't powered to look at that specifically. I think the point there is that it is possible, it can be done, but the majority of patients should be counseled early on that a cesarean section is likely in their future. The average delivery of triplets is around 32 to 33 weeks. That is unchanged for over 30 years. There have been multiple studies looking at treatment methods or things that we've tried to prevent preterm delivery, including progesterone, IM or vaginal progesterone. There's been no benefit found. There's no benefit of cervical length screening in this group. There's no benefit of cerclage. And bed rest, home monitoring, and tocolytics have not been shown benefits in multiples in general. So recommendations are to deliver uncomplicated trichorionic triplets at 35 to 35 and 6 weeks. Earlier delivery may be considered for non-trichorionic placentation. And the risk there, and those are from this recommendations from the NICE guidelines, is that after 36 weeks, we know the risk of IUFD can increase. Risk of complications vary by gestational age, but outcomes for individual triplets are similar to age-matched singletons. I think that's reassuring to tell patients that just because you're a triplet born at 28 weeks, you're not behind the 8 ball. You have the same, should have the same outcome as other 28 weeks singleton. Telling someone in the first trimester how they're going to do in the triplet pregnancy is really impossible, and we don't have many things to tell them, to say, I don't know how you're going to go through this pregnancy. We don't know exactly what will happen. We do know that there are some negative prognostic factors, and those include a prior history of pregnancy loss or pregnancy complication. Bleeding in the first or second trimester is a negative prognostic factor, and monochorionicity. Parity is the only positive prognostic factor, so parous women are more likely to deliver after 32 weeks with triplets, and parous women are less likely to have a spontaneous preterm birth or an indicated preterm birth. Dichorionic triplets, or triplets with a monodi pair, occur in about 44% of spontaneous triplets and 24% of those that are related to ART. The estimated gestational age at delivery is earlier, and birth weights are lower for these triplets, and they're 5 times more likely to have neurologic morbidity and stillbirth related to many of the things you just heard about for monochorionic placentation. Twin-twin transfusion occurs in somewhere between 5 and 24%, and that significantly contributes to perinatal mortality. Some centers offer laser treatment, but this of course carries a risk to the unaffected co-triplet as well. So that's variable by center. Multifetal reduction was developed during the early decades of ART when there were so many higher order multiples. And MFR for triplets, though, quickly became the most common indication. As more procedures were done, the method became standardized and complications became less common. And many series described outcomes of triplets versus twins, or triplets reduced to twins. In a meta-analysis of 24 studies comparing triplets to twins after MFR, there are better outcomes after MFR, including a higher gestational age of delivery, a higher birth weight that goes along with that higher gestational age of delivery, and a lower neonatal mortality overall. There's really no overall increase in survival, as you can see with multifetal reduction with quadruplets or higher order multiples, for example. There is a 60 to 70% reduction, though, in that extreme preterm delivery range. And I think that's the most compelling argument for many patients, is that chance that they will not have 3 25-weekers in the NICU is reduced. There's no difference in their loss rate less than 24 weeks, which speaks to the safety of the procedure. And because you're decreasing the number of gestations, the mom's risk of hypertensive disorders, gestational diabetes, and cesarean delivery are also decreased. I will talk for a minute about delivery and postpartum. We've already mentioned the uterine overdistension and the increased risk of uterine atony. They also have a higher chance of blood transfusion and a gravid hysterectomy. There's a higher chance of postpartum depression, which I'll go into in a minute. And I've had a couple of patients with severe rectus diastasis over the years who've needed some kind of surgical repair. It's uncommon, but these are the patients where that can happen. There's a question of who should care for triplets, and I think that obstetric providers with experience in caring for triplets should be involved. Comprehensive counseling is required, and it's essential in the first trimester. So ideally through consultation with maternal fetal medicine. I think that many different providers could do a cesarean delivery of triplets at term, but managing and really counseling about the complications early on is difficult. You need to see someone who's dealt with it before. The risks and potential complications have to be reviewed. Our limited ability to predict outcome needs to be, explained in a straightforward manner. The impact of placentation can be taken into account. You have the opportunity for prenatal diagnosis and also multifetal reduction for those who want it. And then counseling about the general course of the pregnancy. So carrying triplets is physically demanding. I tell all my patients this, and very few of them remember until the 32-week range creeps up on them. Antenatal hospitalization is common, and need to be prepared for that. That could be short or recurrent or a longer stay. And cesarean delivery is expected. I'm going to put in a picture here of one of our former residents who's an identical triplet, and they're all OBGYNs, all working in Miami. So I think she has a little experience. But I'm going to go through the management steps for triplets. The ultrasound exams before 12 weeks is needed to establish dating, determine the chorionicity as we discussed. Surveys at 18 to 20 weeks, and then serial growth scans for looking for growth discordance, fetal echo certainly for those with IVF pregnancies, or if there is a monochorionic pair, is recommended at 20 to 22 weeks. An MFM consult should be arranged so that ideally before 12 weeks to discuss the pregnancy and management options, talk about multifetal reduction, the increased risk of aneuploidy, the risk of fetal anomaly, what would it mean if one was severely growth restricted, what could happen if there was a demise, and how we're going to screen if there is a monochorionic pair. We talk about nutrition and weight gain, and we recommend vitamin and micronutrient supplementation. We talk about appropriate weight gain in pregnancy. We recommend aspirin, low-dose aspirin, to reduce the risk of severe or early onset preeclampsia. And then antenatal testing will be recommended depending on chorionicity and amnionicity, other complications that may arise, timing of delivery, and postpartum. These patients need to be seen closely, particularly for postpartum depression. These recommendations are adopted from the SMFM guidelines, and this is actually from twins, where the idea is that instead of taking one multivitamin with iron, you take 1 and 2, and then continue that through the pregnancy. And calcium, 1,500 milligrams, increase it to 2,500. Vitamin D throughout, magnesium, which can be covered here, zinc, and folic acid, 1 milligram throughout, as well as vitamin C. There's no evidence-based guidelines for what the best weight gain is during pregnancy with triplets. The extrapolation from the NAM guidelines for twins could suggest that the total weight gain would be around 54 pounds or 24 kilos for normal weight women, about 23 kilos for overweight women, and 19 kilos for obese women. The limitations of these though are that the guidelines were for twins at term. And again, most triplets deliver preterm, and there's no distinction between degrees of obesity, really. One retrospective study showed that weight gain of about 36 pounds by 24 weeks was associated with a lower rate of SGA in triplets. I'd be interested to see if that can be duplicated. I'll mention the psychosocial impact of triplets because there have been several studies done on this, and the first idea that you're having triplets is one of oh my gosh, how are we going to handle this? It does cause significant mental and emotional exhaustion caring for triplets, and mothers of multiples are more likely to have postpartum depression, feelings of fatigue, stress, depression, and they're more likely to question their choice to parent, and that lasts into childhood, actually. And many women with triplet pregnancies are likely to have struggled with infertility, which is associated with anxiety and emotional stress to begin with. So it's a lot to handle. The impact of multifetal reduction is a different question, but the decision to proceed with MFR does carry significant emotional stress and anxiety. It does decrease over time, and the stress of MFR is less compared to selective termination due to an anomaly. Anxiety and emotional burden surrounding the procedure is usually short-term, and it's temporized by the patient's desire to have a healthy pregnancy and the feeling that that was the indication for the procedure. Grieving can be difficult due to the nature of the procedure. There's no visible evidence of the loss. And about a third of women who experience an MFR may have continued guilt and sadness even 1 year after birth. There's also an economic impact of triplets. Hospital costs per family of triplets are 10-fold higher than singletons in the US. And that's mainly because of antenatal hospitalization, the NICU admission, and complications of prematurity. The majority of parents report a need for additional help and financial support for child care, household, and medical expenses. And triplet families are 3 times more likely to have difficulty meeting basic material needs than families who just have a singleton. And often one parent does not return to work, reducing their income and increasing their financial strains. So families of multiples are more likely to have marital strain, with financial stress cited almost always as the most common cause. So that's a whirlwind tour through triplets, and I thank you for your time and attention and look forward to seeing what kind of questions come up in the chat.
Thank you, Dr. Craigo. That was a great talk and a great overview. Again, for everybody, please, if you do have questions, put them in the Q&A box, not in the chat box, because we will only work through the Q&A questions. And I'm just going to start with the questions for Dr. Lewi maybe first, and that will give some time for questions for Dr. Craigo to come up. I think Dr. Lewi, one of the first questions that came up is a little bit what is the risk of co-twin demise after selective IUFD? So one fetus dying in selective IUGR. And the follow-up that came to that is there a residual risk to the surviving twin if this pregnancy has undergone laser?
Yeah, thank you very much for that question. So if there is spontaneous demise in type 3 selective growth restriction, that has been well documented, and the risk is at least 50% that you lose the appropriately growing twin as well because of the large communications. It's very interesting that we don't have any data on type 2, but these type 2 cases are quite rare. And like I showed in type 2, you have very small communication, so you expect that there is less risk of co-twin demise or brain damage if the smaller baby dies in a type 2 selective fetal growth restriction. But we don't have any data on that, so hopefully in a couple of years we have more information on that. But I expect that the risk for the normal growing twin is less in a type 2 than in a type 3 case. In type 3, we know that at least 50% of normal growing babies dies as well if there is a demise of the smaller baby. Regarding the risk of brain damage, if you have a single death after laser surgery or after cord occlusion, there are no good data on that. I think if your procedure is well performed, then you don't expect any exsanguination, but you have to be aware that the underlying disease process, like severe selective growth restriction or TTTS, can also be an important cause of brain damage. So in our series, and that's mostly double survivors, we know that the risk of brain damage for the twin, and that's then mainly because of the twin-twin transfusion syndrome, is about 5%. So it's something that you have to look out for if you have selective fetal growth restriction or TTTS, whether one baby dies or or both survive. So it's a concern in all complicated monochorionic twins.
Thank you very much for that answer. I see a lot of questions coming up for Dr. Craigo regarding NIPT in triplets. And there is one person asking whether you do have any data on the validation of NIPT and or whether people are working on that. Other people say that Maternity 21 offers NIPT for triplets and questions a little bit the validity there. Do you have any comments there?
That might be new, but I thought that no one had actually validated it clearly in triplets. It makes sense that it could work, but we have not been offering it in the commercial labs here for triplets.
No, and I think that certainly, yeah, the international recommendations don't support using NIPT in triplets yet because you get a dilution of the fetal fraction, but the labs will probably always try to do more than what the guidelines necessarily recommend.
And also, they can't give you a sensitivity or specificity. You know, that's the problem. You're using a screening test, but you can't really tell the how well it performs. So you're giving reassurance without that might not really be there.
Correct, and given the small numbers of triplets around, it will be really hard to validate that. Yeah. One more practical question: what is the maximal gestational age you would consider delivering uncomplicated triplets at? Do you let them go all the way to term, or when would you deliver them if they're uncomplicated?
I now try to deliver at 35 to 36, but I have delivered completely uncomplicated triplets at 36. In the past, years ago, I have gone to 37 before, but we deliver at 35 to 36.
I see Dr. Lewi nodding at the same time. Is that the same thing you would do in Belgium, Liesbeth?
Yeah. I think the main concern is postpartum hemorrhage. No, if the fetal mass becomes too big, then yeah, you start worrying about. I mean, and that's the main complication that we see in triplets is like these uterine atonies, and it's related to the fetal mass. So I think it makes sense. Like once 36 weeks, I don't think you have a lot to gain by postponing birth in triplets.
And then when the babies are there, how do we support these families? Because Dr. Craigo, you clearly showed that there was an increased risk of virtually everything, socioeconomically, mental health issues, all these things. How or what services do you offer to these families to support them?
So in the U.S., unfortunately, some of the support, some of their services will depend on their different insurance companies. We offer social work in our clinic, and we talk to them about these issues early on so that they know that's an issue. And I have to say, over many years, that's people care about that, and they think about that when they're considering multi-field reduction. And like they'll say, I don't know how we would do this. I don't know how we can stop working. I don't know how we would be able to care for this. So it's a factor that people do consider when they're planning what to do with the pregnancy. After birth, we have lots of different things we offer. We have visiting nurse, for example, that can see the patients after, shortly after birth for the first few weeks, but it doesn't last, through that first year. And so I really encourage my patients to not plan to do this alone, that they need to have support, like maybe from their community, from their church, from their family, whoever they can find, from their friends, to to accept help when people offer, and to make a plan for that, because it is difficult. And I think there are actually numbers that there's a fair number of patients on either divorced or on antidepressants or anxiety meds by the end of the first year. So it's not trivial.
And then maybe one last question for Dr. Lewi, looking towards the future. A question came up about I think they meant the TRAPPIST trial, the TRAP registry. So the trial that you're currently doing in TRAP sequence in monochorionic twins, early interventions versus late intervention. Can you update us a little bit on the progress there?
Yeah, so I didn't go into much detail about that, but for TRAP sequence, like I said, reduction in monochorionic twins is usually only offered from 16 weeks onwards. But in TRAP, we now know that there is a very high lethality between the diagnosis in the first trimester and 16 weeks. So we're exploring whether a first trimester intervention in TRAP may prevent the 30% loss that we now have. And so we are at the stage of, we randomized a third of our required number of patients, and we're not now at the stage of the interim analysis. And thanks also to the center in Toronto that's now recruiting, then yeah, we hope that we can answer that question, whether we're improving the outcome for TRAP that is now more and more diagnosed in the first trimester, by offering treatment in the first trimester as well, rather than waiting until 16 weeks. But if the interim analysis is favorable, then we continue to randomize patients in the trial, because there's still equipoise. There are some studies that show very good results, but there are also studies that show that there is an increased risk of miscarriage and co-twin demise. So the jury is still out.
Thank you very much, and thank you especially to you both for enlightening us here on the topic of complex multiples. I think that for the audience, for those that are interested, prenatal diagnosis will have a special issue on complex multiples that will probably come out in November. So please watch your mailboxes and watch the website for that. With this, I want to conclude this October session of the ISPD Virtual Education Series. Thank you again, everybody, for joining us, and a special thank you to the speakers. The presentation was recorded, and for those of you who were not able to tune in for the full presentation, the presentation, the recording will be available on the ISPD website, usually within a week's time. We will also send out certificates of attendance for today's session within 2 weeks, within 15 business days. We will have another virtual education series next month on Wednesday, November 17th, and watch your mailboxes or visit the ISPD website for more details. That session will be a little bit more genetics oriented, and we'll be addressing many of the issues that come up with NIPT at this time. This being said, thank you very much again, and have a great rest of your day, or a great rest of your evening, depending on where you are. Thank you very much, everybody.